Hello, I'm Dr. Edgar Milford. I'm the director of the Brigham and Women's Hospital Tissue Typing Laboratory and a senior physician in the Renal Division Department of Medicine. I am also the John P. Merrill and Charles B. Carpenter Chair.
My name is Melissa Young. I am the medical director of the Brigham Tissue Typing Laboratory and an associate physician in the Department of Medicine Renal Division as a transplant nephrologist. And today we will be presenting some transplant cases for board review. Here are our disclosures. So let's jump right into some cases. So this first case is a 53-year-old Caucasian man. He had ESRD secondary to diabetic nephropathy, and he underwent a deceased donor kidney transplant 6 months ago. He had been induced with rabbit ATG or thymoglobulin, and then is now on maintenance therapy of tacrolimus, mycophenolate, and prednisone. He's about 6 months out now and comes to you after his course was complicated with acute cellular rejection, which was graded as BAMF 1B, that occurred approximately 8 weeks after transplant. That ACR was treated with thymoglobulin and high-dose steroids. His graft function eventually stabilized out to a creatinine of about 1.5. And today he feels overall well, and his physical exam is unremarkable. His serum creatinine, though, is now elevated to 2. CBC is within normal limits, and his tacrolimus trough level is at 8 nanograms per milliliter. A serum PCR for BK polyoma virus is positive for the first time at 80,000 copies per ml. So which of the following statements is most correct regarding the management of his case? Would you A, give him another course of thymoglobulin and high-dose steroids for suspected acute cellular rejection? B, perform a biopsy followed by decreasing his maintenance immunosuppression if there's no evidence of acute rejection? C, start cidofovir? D, switch from tacrolimus or to sirolimus? Or E, add leflunomide to his regimen? So the answer here is B. The correct approach is to perform an allograft biopsy followed by a decrease in his maintenance immunosuppression if there's no evidence of acute rejection. And so here what we're getting at is with the positive BK viral load, one needs to consider the possibility of BK nephritis as the cause of his elevated serum creatinine. The definitive diagnosis of which requires a biopsy, but also so that you can rule out the possibility of a concurrent acute rejection, which occurs in roughly over 50% of patients who also have BK nephropathy. Importantly, they also have similar histological features with interstitial inflammation. But the things that distinguish BK from ACR histologically are if you actually see BK viral inclusion bodies, evidence of virally infected cells, typically the tubular epithelial cells is where the BK virus likes to replicate. And of course, if you do special immunohistochemical staining for SV40. Options B through E are incorrect because there's a lack of good evidence for any treatment strategy these days other than reduction of immunosuppression for treatment of BK. Right, so case 2 is a 45-year-old Asian man with polycystic kidney disease, and he underwent deceased donor kidney transplant about 6 weeks ago. His first transplant had failed due to chronic rejection. His creatinine has been stable and excellent with a creatinine of 1.2. And his last routine lab testing revealed a creatinine of 1.2 and a tacrolimus level of 10. 5 days ago, he underwent a EGD for ongoing odynophagia and was actually diagnosed with Candida esophagitis, so he started on fluconazole. Today, he reports that the odynophagia has resolved and he feels well. And his CBC currently is within normal limits, but now you notice that his serum creatinine is acutely elevated to 1.6. So which of the following statements is most correct? Would you A, start pulse steroids since he is at high immunological risk for rejection? B, wait for the tacrolimus level to come back since fluconazole can significantly increase tacrolimus metabolism? C, wait for the tacro level to come back since fluconazole can significantly decrease tacro metabolism? D, switch tacro to cyclosporin since the latter has no interaction with fluconazole? Or E, arrange for an urgent biopsy to rule out rejection and or calcineurin inhibitor-induced thrombotic microangiopathy. So the answer is C. You would want to wait for the tacro level to come back since fluconazole can significantly decrease tacrolimus metabolism and therefore increase the serum tacrolimus levels. And that's because of the interactions that occur between antifungal agents and calcineurin inhibitors. And both cyclosporin and tacrolimus are metabolized by the cytochrome P450 system. And so in the presence of antifungal agents, as well as some calcium channel blockers, you can markedly increase CNI levels by the inhibition of CYP3A. So whenever you're starting or stopping these agents, one must be careful to monitor or adjust these medications appropriately. Case 3, this is a 52-year-old Hispanic woman with end-stage renal disease from diabetic nephropathy. She underwent a living-related renal transplant from her sister about 18 weeks ago. Her donor CMV serostatus was donor positive, and she herself, her CMV serostatus is positive as well. In terms of their EBV serostatus, it's donor negative and recipient negative. For induction, she got thymoglobulin and is now on tacrolimus, mycophenolate, and prednisone. She comes to you in clinic and reports ongoing diarrhea, nausea, and bloating. Her physical exam is unremarkable. Her labs show a hemoglobin of 8, white cell count of 1.4, and platelets of 90,000. Creatinine is stable at 1.2, and her tacrolimus level is 8. She currently takes tacrolimus 3 milligrams BID, 1 gram BID of mycophenolate, and prednisone 5 milligrams daily, as well as valganciclovir 450 milligrams daily and cotrimazole single strength daily. So which of the following statements is most correct? Would you A, decrease her MMF dose and send a serum CMV PCR? B, decrease her tacrolimus dose and send a serum CMV PCR? C, continue MMF at the current dose since diarrhea and nausea are rare side effects? D, stop valganciclovir since she has leukopenia and is at low risk for CMV infection? Or E, increase the valganciclovir to start empiric treatment for CMV? So the answer here is A. You'd want to decrease the dose of her mycophenolate and send for a serum CMV PCR. And so this highlights some of the more common side effects of mycophenolate, which are related to the GI tract, with diarrhea occurring in up to 1/3 of patients and varying degrees of nausea, dyspepsia, vomiting, dyspepsia occurring in about 20% of patients. Some patients report that if you reduce the drug dosage, the total daily drug dosage, or split the total daily doses into 3 or 4 doses, that some of these side effects improve. Additionally, the enteric-coated formulation has also anecdotally improved some symptoms in some patients. Importantly as well, MMF can cause pancytopenia, and this again also usually responds to reduction in dose. Valganciclovir can obviously cause leukopenia, but stopping it would be premature since she's at moderate risk for both reactivation of latent CMV and superinfection with a new strain. And CMV infection itself can cause leukopenia, but starting empiric treatment before confirming the presence of CMV viremia would be premature since she's also been on prophylaxis. So the likelihood that she has CMV disease is much lower. Case 4, this is a 45-year-old woman who underwent deceased donor kidney transplant in 2008 due to FSGS. Her creatinine has been stable at 1.3 on tacrolimus, MMF, and prednisone. An MRI reveals a circumferential mass involving approximately 4 centimeters segment of the jejunal loop in the left upper quadrant without evidence of obstruction. So you suspect post-transplant lymphoproliferative disorder, or PTLD. Which one of the following statements is correct regarding PTLD after kidney transplant? So A, the EBV seronegative status of the recipient at the time of transplant and induction with T-cell depleting agents have been associated with an increased risk of developing PTLD. B, PTLD only occurs in the first year after transplant. C, while the majority of cases are not caused by EBV, EBV-associated PTLD does occur. D, rituximab is not an effective treatment option. Or E, treatment includes an increase in basal immunosuppression. So the answer here is A, that the EBV seronegative status of the recipient and induction with T-cell depleting agents are associated with an increased risk of PTLD. And additionally, while the incidence of PTLD does appear to be highest in the first year when the patients are most immunosuppressed, there is a cumulative incidence over 5 years, and you can get it after the first year. Most PTLD cases are associated with EBV. However, EBV negative disease does occur. Most are non-Hodgkin's lymphoma of B-cell origin and are CD20 positive and therefore do respond to rituximab. Alternatively, other treatment options include lowering the basal immunosuppression or the maintenance immunosuppression, or giving CHOP alone or in combination with rituximab. Case 5. So 65-year-old who has end-stage renal disease from polycystic kidney disease, who presents to your clinic 8 months after a living donor kidney transplant from his nephew. You see his serostatus is CMV donor positive, recipient negative, and his EBV serostatus is donor positive, recipient negative. His course was complicated by an episode of acute cellular rejection, grade BAMF 1B, about 5 months after transplant, which was treated with thymoglobulin and high-dose steroids. Today, he reports fever, chills, and malaise. He's tachycardic and febrile to 103 degrees Fahrenheit. His labs show a hemoglobin of 7.5, white cell count of 1.2, and platelets of 95,000. His serum creatinine is 1.4, and tacrolimus level is 7. He has transaminitis with an elevated AST and ALT, and his UA is unremarkable and chest X-ray is pending. He's on tacrolimus, MMF, prednisone, and cotrimoxazole for prophylaxis. So which one of the following is most correct regarding his case? Would you A, arrange for a renal allograft biopsy to rule out BK nephropathy? B, send serum BK polyomavirus PCR and start IV cidofovir while awaiting the result? C, CMV disease is unlikely since the patient is CMV seronegative and therefore at low risk. D, PTLD is unlikely since the patient is EBV seronegative and therefore at low risk. Or E, the initial workup should include a serum CMV PCR. So in this case, the answer is E. The initial workup should include serum CMV PCR. In terms of looking at the patient's risk status, because the donor is seropositive and the recipient was seronegative, that puts them at the highest risk for CMV infection and disease. Additionally, he received recent T-cell depleting agents in the form of thymoglobulin and high-dose steroids, putting him at further risk, and he was not on CMV prophylaxis. CMV PCR is the test of choice in the serum to detect CMV or diagnose CMV, viremia, and disease. You also noticed that he had a transaminitis. He had pancytopenia, all sort of, and fever, all sort of which point to potential CMV disease.
This next case is a person with lupus nephritis and had gotten a second deceased donor transplant 3 weeks ago. This transplant was CMV donor positive, recipient positive, but EBV donor positive and recipient negative. And the first transplant failed because of antibody-mediated rejection. The current transplant was characterized by some delayed graft function and the need for some hemodialysis. And a dialysis, a transplant biopsy done a week after this second transplant showed a lot of acute tubular necrosis. Approximately a month later, the patient still was dialysis dependent, and a repeat biopsy showed still some ATN with neutrophils in the peritubular capillaries with C4D staining that was diffusely positive in the peritubular capillaries. The ultrasonography was unremarkable. She's on maintenance with tacrolimus and mycophenolate. Which of the statements was most correct regarding your case? Would you do an allograft biopsy to rule out BK? Would you check for antibody against HLA and do some plasmapheresis and IVIG? Would you start treatment for T-cell rejection with antithymocyte globulin and steroids? Would you send a serum BK, PCR, and decrease the mycophenolate dose? Or would you switch from tacrolimus to belatacept because of the fear that calcineurin inhibitors are delaying recovery? Well, it is important to repeat the cross match if possible and to measure DSA in the recipient. So that was A and B. But the histologic appearance of antibody-mediated rejection can look like ATN. And you can have neutrophil margination, peritubular capillary involvement, thrombotic microangiopathy, or fibrinoid necrosis. It also occurs very often in patients who have proven pre-existing sensitization, as this patient did with the first transplant. The problem is that acute antibody-mediated rejection doesn't usually respond to the usual treatments for T-cell mediated rejection, and switching to belatacept would really not help in acute ABMR. And there's also a risk of PTLD in patients who are EBV seronegative. So number E is out of the question. So the answer was as we saw. The next case is somebody who came in with ESRD from reflux and had a 4-year-old deceased donor transplant, had biopsy-proven antibody-mediated rejection, and was treated with pheresis and IVIG. He was on maintenance with MMF and tacrolimus and prednisone. And the creatinine had been creeping up from 1.5 to 3 over the past year. The biopsy showed glomerular capillary wall thickening and a double contour appearance, intimal fibrosis, and some mononuclear cell infiltration intimal. There's interstitial fibrosis and tubular atrophy, and the C4D staining in the peritubular capillaries were positive. A has anti-HLA antibody against the donor been associated with chronic ABMR? Is it true that it's ruled out that the person has ABMR if there is no anti-HLA antibody? And is it true that chronic ABMR is a rare cause for chronic allograft failure because of more potent immunosuppressants that we're using? Or does it usually respond to treatment with pheresis, IVIG, and pulse steroids, or respond well to Rituxan? Well, the DSA in itself has been associated with lower long-term graft survival, and it's very often associated with proven anti-HLA antibodies against the class 2 antigens of the donor. It is true that anti-endothelial antibodies that are non-HLA have on occasion been implicated as potential causes for antibody-mediated rejection. And those MICA antibodies are expressed on endothelial cells and are polymorphic. They can be targets of antibody-mediated rejection. Despite immunosuppression that we are using, which is more powerful, it still is true that a lot of the chronic allograft loss is due to antibody-mediated rejection. And in some cases, 60% of patients show evidence of antibody-mediated injury. And the treatment is really difficult. There are no really proven and definitive ways of treating, in particular, use of pheresis, IVIG, Rituxan, bortezomib. Those remain unclear benefit in terms of the quantitative aspects. This next case is a case of a middle-aged woman who suffered lupus nephritis in the past, had a deceased donor transplant, and was treated with basiliximab for induction therapy, and then was put on tacro, mycophenolate, and prednisone. Her allograft bottomed out at 1.1 milligram per deciliter creatinine, and the follow-up showed an elevated creatinine to 1.8. The tacro level was 5, and an ultrasound showed the allograft to be 10.2 centimeters without hydronephrosis. Biopsy showed prominent interstitial inflammation, focal tubulitis, mild to moderate intimal arteritis, but it was negative staining for C4D. What's the most correct answer regarding her case? Number one is, A is that the patient has acute antibody-mediated rejection, and one should treat with pheresis, IVIG, and pulse steroids. Or you might think that the patient has acute T-cell mediated rejection, and treating the patient with belatacept and pulse steroids should be done. The other possibility is that you think the patient has T-cell mediated rejection and should be treated with ATG and pulse steroids. Or you think that the patient has no BK nephropathy because the patient has an acute rejection. Well, the real definition of acute T-cell mediated rejection, based on the Banff criteria, a cooperative set of standards, depends on 3 issues. One is tubulitis, second, interstitial inflammation, and third, arteritis. And the presence of endarteritis is classified as T-cell mediated rejection type 2. Thymoglobulin and pulse steroids are usually the treatment first used for severe T-cell mediated rejection, and pheresis and IVIG are used for antibody mediated rejection. and belatacept is not appropriate for such treatment. The last issue is the issue of diagnosis of BK nephropathy, and BK nephropathy and acute cellular rejection can definitely occur concurrently, and that can be shown by immunohistochemical staining and in situ hybridization. This is a case of a 69-year-old man with diabetic nephropathy causing the ESRD on dialysis for a year prior to getting a kidney from a 61-year-old person. And the cold ischemia time in that kidney was 28 hours. Patient remained oliguric, was dialyzed because of hyperkalemia and volume overload. And on day 10, the patient had diffuse tubular injury with negative staining for C4D. The patient had received basiliximab for induction and was treated with maintenance tacro, mycophenolate, and prednisone. 3 weeks later, he came in with a urine output of about 300 mils in 24 hours, still dialysis dependent, and the blood pressures are relatively well controlled. He had a little bit of leg edema, but otherwise unremarkable. And the laboratory tests showed a serum creatinine of 8.4 and a tacrolimus level of 8. Is the most common cause of DGF acute rejection? Is the risk for delayed graft function nearly the same for kidneys procured from donors after cardiac death? This patient's risk factors for DGF include cold ischemia time and calcineurin inhibitor therapy. Is that true? Compared to storage in cold solution, machine perfusion has never been shown to reduce the risk of DGF. Is that true? While DGF greatly impacts 1-year graft survival, it has no impact on long-term graft function or patient survival. So which is true? The answer is C. The incidence of DGF increases with higher donor age, donor hypertension, and hypotension, cold ischemia times exceeding 24 hours, and calcineurin inhibitor therapy. And a lot of the causes of DGF are related to events surrounding organ procurement and ischemia reperfusion. The incidence of DGF is pretty high in donors after cardiac death, about 70%, as opposed to about 20 to 50% in non-DCD kidneys, and only 5% in recipients of live donor kidneys. And machine perfusion has been definitely shown to reduce the risk of DGF and graft failure compared to the static cold storage. And both graft and patient survival rates are adversely affected by kidney source and development of DGF. A 50-year-old woman who had adult polycystic kidney disease on maintenance hemodialysis comes in for evaluation now of kidney transplant. She had hypertension and dyslipidemia. The patient thinks that kidney transplantation can cause diabetes and worsen dyslipidemia and asks you for information about it. She's interested in kidney transplantation, but is concerned about the impact it can have on her long-term health. What's most correct regarding this issue of cardiovascular disease and kidney transplant? One is that the annual rate of both fatal and non-fatal cardiovascular disease in kidney transplant recipients is nearly similar to the general population, or the kidney transplantation is known to reduce mortality compared to dialysis despite significant increase in cardiovascular risk after kidney transplantation, or CMV seronegativity is associated with increased risk for cardiovascular death in kidney transplant recipients. New onset diabetes mellitus after transplantation can occur as a result of insulin resistance, increased insulin metabolism, and/or diminished insulin secretion. And last, hyperlipidemia and hyperglycemia are less marked with cyclosporin than with tacrolimus. Now, the answer is D. That is, that new onset diabetes mellitus after transplantation can occur as a result of all three of these functions, that is, insulin-resistant increased insulin metabolism and or diminished insulin secretion. The patients with a transplant have a lower risk of fatal and non-fatal cardiovascular events compared with waitlisted patients on dialysis, but they have a much higher risk compared with the general population. And it's a leading cause of mortality and morbidity and death-censored graft loss after kidney transplantation. Reduced mortality after kidney transplantation compared to dialysis may be largely due to the reduction in cardiovascular risk associated with improved kidney function that a successful transplant provides. And CMV seropositivity has been associated with increased risk for death as a result of cardiovascular disease. And hyperlipidemia is less marked with tacrolimus, so that lipid levels may decrease when patients are switched from cyclosporin to tacrolimus. Hyperglycemia is more common, however, with tacrolimus.
So the next case is a 27-year-old woman who had end-stage renal disease from primary FSGS, and she wants to know about the possibility of pregnancy after transplantation. So which of the following is most correct regarding this issue? Is it that the pregnancy rate after kidney transplantation is nearly similar compared to the general population? Or B, she can attempt to become pregnant as soon as her creatinine starts to decline, since her risk of graft dysfunction will be low? Or C, pregnancy has a significant unfavorable effect on long-term graft function, regardless of what her baseline allograft function ends up being? Or D, mycophenolate is associated with an increased risk of congenital malformations and therefore is absolutely contraindicated during pregnancy? Or E, the use of cyclosporin in pregnancy increases the incidence of hypertension and therefore is absolutely contraindicated? So the answer here is D. The importance of knowing that mycophenolate is associated with fetal congenital malformations and is absolutely contraindicated during pregnancy, such that the US FDA mandates that all female transplant recipients acknowledge that they've been counseled about these risks, and often post-transplantation will make sure that there is some sort of contraception occurring to prevent this from happening. Because of this, for those that are post-transplant who are wanting to get pregnant, we often will have to change them from mycophenolate to something else, such as azathioprine, which is safe for pregnancy. Typically, we like to wait at least a year after transplant before entertaining the possibility of pursuing this. And only once the allograft function has been stable with a creatinine less than 1.5 with no or minimal proteinuria. And in those instances, there's a 90% incidence of a successful pregnancy. And most studies as well don't show that pregnancy has an unfavorable effect as long as their baseline allograft function remains excellent and stable. So which of the following is the most correct about side effects of maintenance immunosuppressants? A, both cyclosporin and tacrolimus can cause hypokalemia and hypomagnesemia. B, hirsutism and gum hypertrophy are more common with tacrolimus. C, hypertension and hyperuricemia are more common with tacrolimus. D, sirolimus is associated with de novo proteinuria and exaggeration of pre-existing proteinuria. Or E, since the introduction of enteric-coated formulation of mycophenolic acid, GI side effects from MMF are rare. So the answer here is D. Sirolimus and mTOR inhibitors, including everolimus as well, are associated with both de novo proteinuria or worsening of existing proteinuria. So therefore, periodic urine protein creatinine ratios are often measured on these patients in order to detect this early. Furthermore, we tend to avoid mTOR inhibitors in proteinuric patients because of this reason. With respect to cyclosporin and tacrolimus, all CNI inhibitors can cause hyperkalemia and hypomagnesemia, and actually hypophosphatemia, as in Fanconi-like syndrome. While cyclosporin is mostly associated with increased risk of hirsutism and gum hypertrophy, tacrolimus causes alopecia. Hypertension, hyperuricemia, and hyperlipidemia are more common with cyclosporin, whereas hyperglycemia and neurotoxicity like tremors or confusion are more common with tacrolimus. And as we learned before, the GI side effect profile, while anecdotally might be slightly better with the enteric-coated formulation of MPA, it's not necessarily a significant reduction. So in this case, we have a 55-year-old with ESRD who got a transplant from a 68-year-old donor after cardiac death, cold ischemic time of 30 hours. There was good initial graft function with the creatinine falling to 2.1 milligrams per deciliter. But on post-op day 5, the urine output suddenly falls to 400 cc's in the last 24 hours, and a new modest-sized perinephric fluid collection is seen on imaging. There's good blood flow to the kidney with no evidence of hydro, and a biopsy shows 20% glomerular sclerosis and moderate vascular disease that is thought to be donor-related. Tacro level at this point was 9, and 1 week later, the patient remains oliguric. BUN is 30, and now the serum creatinine is elevated markedly at 12.5. Repeat ultrasound shows a similar sized fluid collection, and repeat biopsy findings are similar. So what is the next best course of action? Do you think we should A, switch the tacrolimus to rapamycin because of CNI-related renal vasoconstriction as the cause of his allograft dysfunction? B, decrease the tacrolimus dose further and repeat a biopsy in another week if there's no improvement? C, continue the current management as the patient likely has ATN from ongoing prolonged cold ischemic time, and the graft function should improve over the next week or so. D, sample the perinephric fluid to rule out a urinoma and do a nuclear scan. Or E, continue the current management as the patient has no pain and the collection likely represents a lymphocele. So the correct answer here is D. You would want to sample the perinephric fluid, and that's because of the possibility of a urinary leak or urinoma should be excluded. One tends to think about this when the serum creatinine is disproportionately high, and it's high because it reflects the reabsorption of urine and therefore creatinine by the peritoneum. So there's intact glomerular filtration, but the creatinine is high because of reabsorption. The presence of vascular disease in the graft makes it a higher likelihood or a higher possibility that there's vascular compromise of a number of the vessels, including the vessels supplying the ureter. And so it's a risk factor for distal ureteric necrosis at the UVJ, and therefore a risk for a urinoma. While a nuclear scan or a pyelogram could show extravasation of the urine, this is often less sensitive, and demonstration of an elevated fluid creatinine levels by sampling the fluid collection is sufficient to diagnose the urinome. So you should have a serum creatinine that's pretty much on par with what you would expect from urine creatinine levels and significantly much higher than serum creatinine levels. This next case is a 27-year-old African-American gentleman with end-stage renal disease from primary FSGS. He underwent a deceased donor transplant about 6 weeks ago. He received thymoglobulin followed by sirolimus, mycophenolate, and prednisone. His graft function has been stable, but then he noticed worsening bilateral lower extremity edema. His lab tests reveal a creatinine of 1.6 and a spot UPCR of 8. His sirolimus trough level is 7. So which of the following statements is most correct? A, the predictors of recurrence for FSGS includes rapid progression of initial disease to end-stage renal disease and the adult onset of the disease. B, this is unlikely recurrent FSGS since the patient is being treated with mycophenolate and steroids. C, the use of mTOR inhibitors have been shown to cause FSGS. D, this is unlikely recurrent FSGS since recurrence of primary FSGS is very rare. Or E, recurrence of primary FSGS is unlikely to occur so quickly post-transplant. So the answer here is C. Again, the use of mTOR inhibitors have been associated with FSGS. In fact, in one study from people who were converted from a calcineurin inhibitor to sirolimus, 64% developed proteinuria, and of these, 30% were found to have FSGS, including collapsing FSGS. If you discontinue the mTOR inhibitor, about a third to a half of these patients will have reversible proteinuria. The reason why A was incorrect is because the major risk factors for recurrence of primary FSGS include childhood onset of the disease, rapid progression of the initial disease, Caucasian ethnicity, and a history of recurrence in the prior allograft. Recurrence is actually pretty prevalent, varying from 30 to 50%, and it can reoccur virtually immediately after transplantation and thought to be due to a circulating permeability factor. So this case is a 51-year-old gentleman with IgA nephropathy who underwent a deceased donor transplant. And his post-transplant course was complicated by delayed graft function, needing dialysis. A biopsy done on post-op day 10 showed severe ATN with no evidence of rejection. He, however, remained oliguric and dialysis dependent, and a second biopsy was done 10 days later, which again revealed ATN. He currently is taking tacrolimus, mycophenolate, and prednisone, and he has read about belatacept on the internet and would like to know whether this would be something that would be appropriate. So which of the following statements is most correct regarding a regimen including belatacept, mycophenolate, and prednisone compared to a CNI inhibitor, cyclosporin, mycophenolate, and prednisone regimen? So A, will the maintenance belatacept regimen help to improve the graft function? B, is he at higher risk of developing post-transplant lymphoproliferative disorder, and therefore belatacept is contraindicated in this patient? C, is he at high risk for developing CMV disease, and therefore belatacept is contraindicated? D, are 7-year patient and allograft survival rates inferior in the belatacept regimen due to a higher likelihood of developing acute rejection? Or E, does switching the belatacept regimen increases risk for cardiovascular disease? So the answer here is A. Maintenance belatacept-based regimens may actually improve renal allograft functions compared to calcineurin inhibitor-based regimens. And this was proven in the BENEFIT trial, where they found that rates of death or graft loss were also significantly lower at 7 years in these patients. The incidence of hypertension, hyperlipidemia, and new onset diabetes after transplant were also lower in the belatacept group. There is a higher incidence of PTLD, specifically in patients who were EBV seronegative recipients who received EBV seropositive kidneys. And for this reason, belatacept is only used these days in recipients that are EBV seropositive. That concludes our board review session for today. We have in your handouts included some additional questions and cases to review, just for interest and additional learning points. Again, if you have any questions about any of these things or would like clarification, please feel free to reach out to me, and my email is as above.